Chapter 35, Emergencies for Patients with Special Challenges. This chapter is especially difficult because really nobody is a true expert on any of this material. Every one disability or special challenge that we discussed today, there's going to be different experts to weigh in on those. At the end of the day, the experts are really the family members that care for this population. Therefore, I'm going to give you some general information, provide you with some of the limited experiences that I have. But beyond that, I think we just need to go into this knowing that every single situation, every call, every scenario requires us to kind of adapt a little bit differently. We have to take time to get to know not only what the needs are of our patient, but how we need to adapt our assessment approach and ultimately our treatment approach. So, a broad definition of disability is a condition interfering with the ability to engage in activities of daily living. Now, again, that's very broad. There's any number of things that could be grouped into that. Arguably, something like alcoholism could be grouped into it. So, when we talk about disabilities and challenges, it could be underlying medical conditions as well as developmental issues such as cerebral palsy or Down syndrome. And from time to time, these things are genetic, where the child is born with it. Other times, it may be something that's developed throughout life, or something that comes about as a result of trauma, such as traumatic brain injuries or strokes, things like that. The source of it is really irrelevant from our perspective in pre-hospital EMS. What we're looking for is strictly what are the patient's needs and how is it that we can provide for those needs. You'll see here that being visually impaired technically classifies as a disability. Same with hearing impaired. These patients may have otherwise led a perfectly normal life, but eyesight went later in life as a result of a medical condition. And again, they'll classify in there as a disability. And I want you to kind of think about something as simple as losing your sight or losing your hearing. Close your eyes and walk around in a strange environment. Or close your eyes while somebody is, performing an assessment or a treatment plan on you, and you'll realize that it's actually very nerve-wracking because you don't know when you're going to be touched. You don't know necessarily why, where, anything else. We need to really be good at vocalizing exactly what we're doing, when we're going to do it, and where we're going to do it. So, for instance, in this situation here, ma'am, I'm going to take a blood pressure on your left arm. All right, we can't just assume that she's going to know which arm it is. We want to try to do our best not to startle the patient. Terminal illnesses from time to time can play into this as well. I'm sure, all know somebody who has or has had cancer at one point in time. Heart failure, end-stage renal disease. There's a lot of different types of terminal illnesses out there. And with these terminal illnesses, beyond simply treating the signs and symptoms of the illness or whatever the complaints are at the time, we also have to take into consideration the emotional component here. The stages of death and dying play out for these patients. And in the event of a terminal illness, those stages may be spread out over the course of weeks, months, or even years. So depending on the stage in which the patient is at the time, and even family members, that can determine how effective we are at providing treatment. If they're in the anger stage, they may be generally disgruntled, they may be combative. A family member may have called because the patient is presenting with certain signs or symptoms, and the patient doesn't want any type of help. So we have to overcome all of those challenges when dealing with these patients and remain compassionate no matter what. So it may depend on technology to sustain life or relieve pain. Isn't that the truth? Technology is everywhere these days. Between automatic respirators, automatic insulin pumps, and everything else in between, there's an incredible amount of technology that is available within our society, especially within the medical fields. So we have to, we're not going to be resident experts on this technology by any means. As a matter of fact, you're going to come across a lot of this stuff, and it's going to be the first time that you ever see it. So take the time to learn about it. It's okay to tell the patient or the caregiver or the family member, hey, I don't know what this is. I don't know how to use it. Can you please help? That's perfectly acceptable. It is absolutely impractical to assume that every EMS provider is going to know how to utilize every specialized piece of equipment out there. Advanced directives will play into it. Remember that while DNR forms are still available out there, the more frequent form that we're going to run into is the POLST, or that physician's order for life-sustaining treatment. And that POLST form is going to be very specific in what you can and cannot do when rendering care. A lot of terminal illness patients, they may not want to be resuscitated. However, they still want comfort care, right? They don't want to suffer as they approach death. So it may allow for the administration of pain medications. They may say that in the event of respiratory distress, you can provide supplemental oxygen. It may simply say that the only thing that you don't do is perform compressions in the event of cardiac arrest, but every other treatment out there would still be executed to the fullest. Obesity is classified as a disability. Now, when you think about this, BMI of 30% or more, that's the vast majority of people that you come across. So obesity does not have to necessarily mean morbidly obese, but technically somebody that's in the ballpark of 250 pounds, depending on their height, that would be considered obesity. So we have to kind of look at that as a consideration and understand that obesity is still going to contribute to some underlying illnesses and some medical conditions, hypertension, heart disease, risk for stroke, etc. But we also have our patients that are truly morbidly obese, 4, 5, 6, and 700 pounds. We have to consider special circumstances in order to treat and especially move these patients. It's going to be difficult to perform basic care. Some of the tools and equipment that we utilize may not fit. Something like a CPAP, for instance, wouldn't be appropriate for these patients because you're likely going to have a hard time maintaining a good seal. You may have to call in additional resources to assist you in lifting the patient, moving the patient. You may need specialty equipment, a special ambulance or a special cot. Additionally, these patients, because of the amount of fatty tissue on them, they're unable to lay flat. Similar to that of a congestive heart failure patient, they need to sit upright because they need to take the weight of that excess tissue off of their chest, allowing for chest expansion. So we're going to allow them to sit in a position of comfort, and that may mean that they need to drape their legs over the side of the cot. It really does just depend on the patient themselves. Homelessness and poverty can be grouped into a disability. That does affect their ability to live everyday life. And what we see associated with homelessness and poverty is the inability to pay for routine medical care, inability to pay for prescriptions. So even though a patient may have a diagnosis of hypertension, they're unable to afford or pay for their medications, and as a result, it goes untreated. These patients are now at risk for aneurysms, strokes, heart attacks, and everything else. We'll see malnutrition play into it. Mental health runs rampant throughout the homeless and impoverished communities. The depression rates and bipolar, suicidal rates, those things are all elevated within those demographics. Substance abuse and HIV, a lot of these things are going to be related to education. We have an association between undereducation and homelessness and poverty. And what that means is that when it comes to substance abuse, a lot of times these younger children, but even adults, aren't properly educated on the hazards of substance abuse. They may not be properly educated on the hazards of HIV and other sexually transmitted diseases. They may not have the money or the education to understand the value of contraception. Tuberculosis can run rampant for sure, and other generalized infections such as pneumonia. With autism, then, this is I'm going to say, probably the most difficult disability to work with. In this situation, there's such a wide spectrum for autism, from very high functioning to very low functioning. And every single autistic patient that you come across will require a customized treatment plan. And even if you are familiar with autism, even if you have a family member, a neighbor, or a friend that has it, you are familiar with their level on the spectrum. But that doesn't necessarily include every other patient that you're going to come across. There are patients that you can adapt and generally deal with changes in their environment. There's others that if there's any change in the environment, any change in routine, it is a catastrophic end to the day. So in these situations, we want to employ the use of mom, dad, caregiver, whoever it is, and say, hey, what's the best way to approach things here? And they're going to have tricks of the trade. If at all possible, you want to keep these patients in, or I'm sorry, you want to keep the caregivers or parents in the ambulance with you so that they can kind of act as a liaison with the parent or with the patient. That patient's going to want that familiar face, and they're going to know kind of some of the tricks to get them to calm down and be cooperative. I'm going to bring up a video here that we're going to watch on autism, and I want you to really think about it. Autism awareness is something, it's a big initiative that's being pushed these days because a lot of times we'll walk up and we'll just assume, or especially law enforcement will assume, that a patient is being non-compliant, when in fact it's an autistic patient and they're just unable to comply at that point. So let's take a second to watch this video here.
As any firefighter or EMT knows, time is never on your side. Minutes, even seconds, can mean lives saved or lost. Any training you have had up until now will not prepare you for this situation.
Hi, I'm Captain John Sokol, the Pembroke Fire Protection District here in Pembroke Township, Illinois. And this is Dylan. Hey, Dylan. Give me 5, buddy. As you can see, Dylan likes fire trucks and a lot of cool things. He's a great boy. He's about 5 years old. But what you don't know about Dylan can change your life. Dylan has autism.
An autistic individual is 7 times more likely to come into contact with an emergency responder than an average citizen. To effectively interact with an individual with autism in an emergency situation, you must know what signs to look for and what to expect. Each encounter can be uniquely different. It is said, when you have met one person with autism, you have met one person with autism. As a first responder, you face some of the following challenges when interacting with an autistic individual: difficulty communicating, lack of reasoning and cooperation, no real sense of danger, low comprehension, aggression, high pain threshold, total shutdown of the individual, just to name a few. Headlines from across the country tell the heartbreaking stories of individuals with autism that have died in emergency situations. As first responders, we can help prevent these tragedies, but only with the proper training. Autism awareness training will help protect Dylan and the other 1 in 100 children that are born with autism each year. It's in your hands. We challenge all firefighters and EMS personnel to start by testing your knowledge. Take the pretest at prevent-educate.org to see just how prepared you are. It's in your hands.
So let's talk a little bit about the ABCs of dealing with patients who have autism. The ABCs for autism in this situation are awareness, basic, calm, and safety. We'll go through each of those individually here. So with awareness, we have to, first of all, obviously be aware of the condition, if at all possible. We have to adapt our approach, meaning that if we come in loud, if we're sudden movements, if we are engaging or touching the patient without giving them advance warning, all of these things can be rather startling and can cause the patient to kind of bottle up or shut down on us. Again, here it says disruption of routine is not well tolerated, and that's the honest to God truth. I was fortunate enough to spend some time working in the life skills classrooms in Woodstock, and during those couple of years, I was exposed to a wide variety of different disabilities, autism being one of the more common ones, though. And with these students, the same person needed to get them off the bus. We walked through the same doors. We walked the same path down to their locker. We first of all hung their backpack up. Then we took their coat off, hung their coat up. We would walk down to the classroom. They'd put papers into a special bin. They would go and get something out of a different bin. It was just all very procedural. And anytime that routine was altered for whatever reason, if there was a substitute teacher because their individual one-on-one aide was out sick for the day, that could alone derail the entire day. So it is, again, very challenging. Communication may be challenging, especially depending on where they are on the spectrum. Be prepared for them not to be compliant, for them not to be engaged, not to communicate effectively. And in these situations, we can't allow frustration to take over. It may be the most appropriate thing not to intervene. If we're doing a basic transport for something simple and we don't see any life-threatening issues, there's no signs of poor perfusion. If the caregiver or parent says that their mental status is appropriate, we may not want to do vital signs. Even the squeezing of a blood pressure cuff is something that could be really troublesome for them. So it would be okay in this situation not to do any vital signs. Maybe we can get away with simply checking a radial pulse just for overall rate and quality. And then we can explain that to the hospital when we call our online report, and they should be okay with that overall. Basic is the next then. Keep your instructions basic. So questions need to be basic. If we're trying to get or determine if somebody's ANO times 4, they may or may not know current events. They may or may not know the day of the week. Conversely, there may be autistic patients that are incredibly brilliant and able to communicate at a level above what we're able to communicate. So they may start talking about things that are far more advanced than even we can comprehend. So we want to just try to do everything as simple as we can, keep it as basic as possible. The C stands for calm, and that means we speak with a nice quiet tone. We're not loud, we speak slowly, softly, gentle movements, no sudden movements or anything else, gentle touches. Everything has to just kind of be slowed down and nice and smooth. And if we can do that, hopefully that will convey to them that it's a safe environment and they will also feel safe, which obviously leads us into safety. So begin treatment where the patient is found. If we simply pick them up and move them right away, that's going to be a bad start to the entire interaction. We want to try to avoid things that are going to aggravate or stimulate. Having the lights on the ambulance as you're parked in the street, that may be inappropriate. The stimulation of the lights or even the siren, if we're transporting to the hospital, could be something that bothers them. Doing our head-to-toe survey, one step at a time, we maybe need to do it by doing it visually. If we can do it without going hands-on, then that's perfect. Where this becomes difficult, obviously, is if this is a trauma patient. And in that event, we need to go hands-on. We need to perform a comprehensive assessment, identify life threats, and provide any necessary treatment. So with those situations, we're going to have to work around it. And at the end of the day, I can't tell you how to do this. I can't tell you there's one way that works better than another. Every single patient you come across, you're going to have to customize your approach and your treatment plan. And that falls into the interpersonal communication and how being an EMS provider requires incredible interpersonal communication skills. We have to be able to communicate effectively with all of our patients. And if we have a difficult time communicating with each other, that's obviously going to really make it difficult to communicate with our patients. So general considerations when responding. Keep in mind that the home now is an extension of the hospital for a lot of these patients. Insurance companies and others have realized that allowing patients to have in-home care, in-home equipment is cheaper than long-term hospital stays. So the patients and their families will likely have a lot of high-tech equipment in the home that is used on a regular basis. As I said earlier, you are not expected to know how to use everything. Moreover, you should just be confident enough to go to the mom or the dad or the caregiver and say, hey, can you please help me with this or show me what needs to be done? Or my personal favorite, can you just do this for me, please? This is a prime example. If you need to transport this patient, what do you disconnect first? Or can you disconnect it? How are you going to hang it? Are those bags, do they need to be hung up? Do they need to be on right now? Can they be disconnected? This one over here on the right, that looks to me like it's probably a feeding bag. Can we disconnect that? Every tube that we don't have to have when we're moving a patient around, less chance of something getting snagged or dislodged. And obviously these settings can be anywhere, right? Private residences, nursing homes is very common for probably everybody. Whether you're in a fire-based EMS, a private EMS, it doesn't matter. Nursing homes are something that we're at on a regular basis. So the caregivers are trained. We've talked about this a few times now. Employ their assistants and ask them to provide any necessary guidance that you may need. Now, along the same lines, we've talked a lot about utilizing the parents, the caregivers, whatever. But at the same time, the patient may be, cognitively aware, ANO times 4, and perfectly capable of providing their own assistance. When we talk about this, if we're referring to a diabetic that has an insulin pump, or if we are referring to somebody who in heart failure that has a left ventricular assist device, these are all things that, while they technically fall into the disability category, it doesn't prevent them from providing or treating themselves to a certain extent. So we can go ahead and utilize their own assistance and expertise wherever possible. You'll see here, this is a patient that is most likely awake and able to communicate with you, and she'll be able to provide guidance on what needs to be disconnected or how it needs to be done. We have lots of different protocols on how to treat just about every single type of patient we may run into. The challenge, though, is that the protocols don't have step-by-step instructions on every piece of equipment or every type of special challenge that we may come across. So in those situations, we're going to have to kind of do a cost-benefit analysis there. Do I have the skills? Do I have the abilities? Do I have the tools necessary to take care of this situation, or do I not? And if I don't have the appropriate skills, tools, or resources, then I need to take a step back and I need to figure out, okay, how can I get them, right? Let's not be reckless here. The last thing we want is to transport a patient with a piece of equipment that we're unfamiliar with, have equipment failure, and then we need to figure out how to deal with it in the back of the ambulance. Diseases and conditions. So we've talked about this stuff throughout the entire semester. There's really not a lot of new material here. This is going to be kind of review. But patients who have chronic conditions or diseases may have something exacerbate all of a sudden. Somebody who has a cancer, for instance, they may develop a secondary infection that exacerbates a lot of the conditions related to the cancer. And in those situations, obviously, they're going to contact EMS in many cases, and we'll have to figure out what's wrong. But at the end of the day, we're just going to simply treat the signs and symptoms. There's not much more beyond that. There's lots of respiratory devices out there that people are on for respiratory ailments such as COPD, CHF, etc. CPAP is something that a lot of people sleep with. This is for sleep apnea, in addition to other respiratory issues that we could use it for. But typically, we're not going to need to transport those machines, and that use is restricted to nighttime in many situations. Tracheostomy tubes. I believe there's a picture coming up. So here, tracheostomy tube is where there's a stoma cut into the neck, or a hole cut into the neck there. And that goes directly into the trachea. And then we're able to put a trach into the trachea, and that's where they breathe. So if the patient is breathing through their neck, that's something that's important for us to note, because if we had to ventilate this patient or suction this patient, both of those are going to be done through the stoma itself. So with the tracheostomy tubes, or the stoma in general, what happens a lot of times is mucus builds up in there, it hardens, it gets crusty, and then we have to try to suction it out. But because it's hard and crusty, the suction doesn't work. So we, from time to time, will have to irrigate it with some sterile water or saline. That's obviously a challenge, because as we irrigate, there's risk of that water or fluid getting into the trachea. So it's kind of a catch-22. What we may end up needing to do from time to time is just ventilating these patients. And if we're going to ventilate them, What we'll have to do is actually use, if it's an adult patient, we would still use an adult size mask, but we would use an adult size bag, but we would use a smaller mask. So in the instance of an adult, we would use an adult bag with a pediatric size mask. And that pediatric size mask would just fit directly over the stoma in the neck. If the trach is in place, meaning the hard plastic piece is in place there, the neck on that trach is typically the same size that fits the BVM. So the same size as the collar on a King tube, an iGel, an ET tube, etc. So that means that we should be able to attach our BVM directly to that trach and ventilate that way. But in the event that trach isn't there, or it's crusted up or anything else, then we can just simply put the mask over the opening on the neck there. Home ventilators, I'm not going to get into that. If they're on a home vent, it's going to be time consuming to get them moved over and prepped, and you're going to have care providers to assist with that. So nothing more to talk about on that. Implanted pacemakers and cardiac defibrillators was discussed during the cardiac chapters. These truly are not disabilities, but what ends up happening from time to time is either a pacemaker may fail, or what we see even more often is a cardiac defibrillator starts firing when it's not supposed to. Obviously, if a patient goes into a dysrhythmia, the defibrillator is programmed to exactly that, defibrillate. But from time to time, they malfunction and they start firing on their own. In that situation, ALS is an appropriate request. We can provide pain medication and sedatives to help kind of take the edge off some of those defibrillations until they can get to the hospital and actually get the device serviced. And yes, it's extremely painful. Think about having a device in your chest that's shocking your heart every few seconds. It's incredibly uncomfortable, I would have to imagine. All right, so we hit on those. The LVADs, left ventricular assist device, again, should have been something that we talked about in cardiac. But in these situations here, the patient's left ventricle is not able to effectively perfuse or pump blood. And you'll actually see that these are now going to be called ventricular assist devices rather than left ventricular, because they are expanding them to work for both the left and right sides of the heart. But essentially what happens here is you've got a battery pack and you've got this pump, and wires go in there, and the pump actually circulates the blood to the rest of the body. So this is really important. The left ventricle, although may still be firing, is not responsible for blood circulation. This LVAD does that. And it's a constant centrifugal pump. So there are no contractions within this pump, meaning the patient has no pulse. So they'll be awake and talking to you, skin parameters look normal, everything's fine, but they're not going to have a palpable pulse. Now, since they don't have a palpable pulse, they're also not going to have a blood pressure, right? Or they'll have a blood pressure, but we're going to be unable to actually auscultate it. So we will not be able to acquire a blood pressure or a pulse for a patient that has an LVAD. So a lot of times people say, well, what happens if, how do we know if a patient's in cardiac arrest? How do we know when to do CPR? And we will assess the respiratory function at that point. If the patient is unresponsive and we don't see any signs of breathing, we're going to assume that they're in cardiac arrest at that point, and we would perform compressions just like we would on any other patient. The cardiac arrest protocols are followed no differently. So kind of a unique thing. With these are so specialized, there's very few hospitals that deal with these. And the patients will typically have a card with them, or it's going to be a sticker on some of the equipment that says, in the event of issues, call this person. It'll give you a phone number. And that's a 24/7 phone number. You call them up and say, hey, I'm with Joe Smith here. He's having some issues with his LVAD. What would you like us to do? And more than likely, they're going to say, okay, if it's life-threatening, take him to the closest hospital. If it's non-life-threatening, or if it can be delayed just a little bit, request a helicopter and have him flown to the appropriate facility. And the last I knew, I believe it's Rush and maybe Christ Hospital down in the city that deal with these. So those are both going to be appropriate to have the patient flown just because of the sheer distance. All right. With the The power sources, so there's a double redundant power source on there, meaning that there's a battery, there's actually two batteries, and the pump runs off a single battery, and in the event that that battery dies, it then switches to the secondary battery. That also works so that we can switch batteries out. So if the patient has one battery that's dead and they need to swap it, then they can rely on the other battery to continue to power the source. As far as NG tubes and G tubes and everything else for feeding purposes and whatnot, we don't need to get into detail as to what they are, how they work. I mean, I think you can get the gist of it. It allows for nutrition to be provided directly to the patient, delivered directly to the stomach. The challenges with G tubes are going to be entanglement. Anytime we're moving patients that have G tubes in place, any types of IVs, tubings, urinary catheters, all those things. There's just a lot for us to get caught up. And I can't tell you how many times I've gone to something like a nursing home. The patient's got a urinary catheter in place with a bag hanging on the side of the bed. Well, they're covered up with blankets and everything else, and we're going to move this patient, and all of a sudden we realize that the bag is getting caught up. And I think we can all picture just how uncomfortable it would be to have that urinary catheter pulled out abruptly. So what we need to do is survey these patients, do kind of a 360 walk around of the bed or the chair that they're in, the wheelchair even, and look for anything that's hanging there, such as the urinary catheters. Look for any tubes that may be linked up there. Make sure that we have them kind of gathered up and prevent them from getting snagged or pulled on whenever we move the patient. So here's an example of a young child that has a feeding tube in place. The caregiver actually puts a liquefied or a pureed food product into a syringe, and they deliver it that way, and it delivers it directly into the stomach. Urinary catheters are what I just talked about. Just, again, be careful. There is a benefit to the urinary catheters, though, and the fact that we can actually see the urine. So in the event of an infection or a suspected kidney issue or UTI, bladder issue, if we're trying to assess whether or not there's blood in the urine, it's nice and easy for us to be able to just look through the bag because it's transparent and we can determine whether or not there is blood present. So this is a great example, right? So keep in mind that this tube is permanently implanted up through the penis, through the urethra, and into the bladder. So if this were to get snagged or caught up, that would get ripped out right away. It would be obviously uncomfortable, but also the potential for trauma and bleeding then from the penis. So be very careful with these. Gather these up. It's not difficult. It just sits there on a plastic hook. You can pick it up with your hands. It's clean. Everything is contained inside the bag, and you can assist the patient in movement then. Ostomy bags are similar to a urinary bag, except this is for bowel content. So instead of a patient, and this is common with like colon cancers and everything else, instead of the patient having a typical bowel movement by sitting on the toilet, there's actually an incision made into the abdomen, and it routes directly into the intestines then. So the bowel content, rather than going out through the rectum, is discharged through the opening in the stomach into this bag, and then the bag is just changed out from time to time. A lot of times these are hidden underneath clothes. People will be fully functioning up, walking around, going to work or whatever else, and they'll have this in place hidden under their clothing. So just something to look for. Again, not a big deal. If we did suspect some type of GI bleed, we could assess for the presence of blood in it. But other than that, just try not to hit it or break it open. Trust me, you and everybody else will regret it if you do. Dialysis we've already talked about in the renal chapter. Several different types of dialysis, hemodialysis and peritoneal. You can go back and review those if you'd like to. The big takeaways here is if they have that AV fistula in place, typically in one forearm or the other, we don't want to do a blood pressure on that side. So anywhere that there's a fistula, we want to avoid doing blood pressure or squeezing in any way, shape, or form. I think those are the big things. Central IV lines and PICC lines. That's not for EMTs, Those are permanently implanted IV access ports that essentially, for patients who are chronically or terminally ill, rather than poking them with an IV needle every time they need to have a treatment, they have these permanently implanted ports. And then the hospital can go in and just access those, and it's a lot easier on everybody involved. EMTs obviously will not access them, and even in most situations, paramedics will not access them. And the last couple slides here on abuse and neglect. Depending on the disability, keep in mind that the patient may be unable to communicate when they are being abused or neglected. We need to be observant for the signs and symptoms, just like we would on every other patient that we come across. Bruises in various stages of healing, inconsistent stories among either a single person or multiple children, signs of neglect, poor nutrition, moldy food out in the house, everything else that you can possibly imagine. Let's see. And that brings us to the end. So the moral of the story for this chapter is simple. Every patient's different. That means you have to customize your approach differently for every single patient you come across. Not just with special challenges, but every patient in general. So keep that in mind, okay? We need to do an assessment not just for what's wrong medically or what types of injuries they have, but we also need to assess personality, communication techniques, and we need to render treatment plans for that as well. Thanks for your time, and we'll see you in class.